Assalamu alaikum and good morning. As all of you know, my name is Sohail Mehboobi, and I'm a National Medical College graduate, and after graduation I came here in USA to do anesthesiology residency and then fellowship in cardiac anesthesia. Now I'm working in my current position in Lehi Clinic Medical Center, which is at Tufts University School of Medicine Hospital. I'll discuss with you in the next half an hour or so the different coagulation management strategies for cardiopulmonary bypass, and with particular focus on direct thrombin inhibitors. With this, let's start. As all of us have vast experience using heparin for anticoagulation on bypass, it's a traditional anticoagulant since the start of cardiopulmonary bypass in the 1950s. It's been used, and it's been used tremendously. It has a lot of good things and a couple of bad things. So the good things are we have a vast experience of using it. We know all the side effects, dosages, and everything about it. It's by action, it's an indirect thrombin inhibitor. It has a short half-life, about like 60 to 90 minutes. And the two most important things which makes it particularly useful for cardiopulmonary can be monitored very easily with activated clotting time, which is ACT. And all of us do it in the operating rooms. And it is easily reversible by the end of the cardiopulmonary bypass with protamine. All these things make it extremely useful for us to be used in the cardiopulmonary bypass in the cardiac patients. Few things about the indirect thrombin inhibitors, and the example is again the unfractionated heparin. It involves catalyst. It needs the antithrombin 3 activity to work as an anticoagulant. It inhibits the coagulation proteins because it has a pentasaccharide sequence, which is at the end of its molecule, and it binds to antithrombin 3, and then it causes inactivation of activated factors 9, 10, 11, and 12. So by doing that, heparin not only decreases the production of thrombin, but also directly inhibits its activity along with the antithrombin 3. So in this slide, the two pathways of coagulation system, extrinsic and intrinsic pathways, and we can see that heparin and antithrombin 3 combination is inhibiting activated factors 9, 12, 11, 9, and 10. So by decreasing that, it decreases the production of thrombin, and directly also, along with antithrombin 3, it decreases the activity of thrombin. And I would like you to consider this bivalirudin here, which is a direct thrombin inhibitor, and we will discuss it in the later slides of our discussion today. It does not require any of these steps. It does not require any catalyst. It inactivates thrombin directly. So a few more things about unfractionated heparin. In higher concentration, which is like 4 to 5 units per ml, it suppresses thrombin activity. And in higher concentrations, it not only do that, but also decreases any kind of coagulation process in the blood. And by doing that, it preserves the coagulation factors and platelets. And all these preserved coagulation factors and platelets can play an important role in coagulation once the heparin is either metabolized or reversed with protamine. So in that way, heparin can be extremely helpful in higher concentrations when used on cardiopulmonary bypasses. Also in the higher concentration, it also releases tissue factor pathway inhibitor, and which directly or indirectly inhibits the platelet function. On the other hand, we have the second class, which is called direct thrombin inhibitors. They do not require a catalyst. Rather, they inhibit the thrombin activity directly. The examples are hirudin, bivalirudin, and argatroban. They all bind with thrombin in one of the active sites or the catalytic active sites, which we'll see in the later slides. All the direct thrombin inhibitors also inhibit the activation, and the platelets, they offer a phospholipid surface on which all the propagation of coagulation factors and coagulation process starts. So by inhibiting the platelet activation, and there's no more phospholipid surface available for the coagulation factors to form the clot. Now, what are the advantages of direct thrombin inhibitors? Well, they do not bind to any plasma proteins. They are not reliable. They do not rely on antithrombin 3, and therefore it is a more reliable anticoagulant as compared to heparin or the indirect anticoagulants. And they also inhibit the thrombin which is bind to the clot. This is the difference between the direct thrombin inhibitors and the indirect thrombin inhibitors. Like heparin in a lower concentration, it does not inhibit thrombin which is already bind to the clot, while the direct thrombin inhibitors in any concentration, they can do that. So the limitations of our heparin, which we use every day in the operating rooms. The heparin binds non-specifically to plasma proteins and endothelial cells. And by doing that, the problem is, especially in the critical care patients, the very ill patients, the response can be variable. So, like at a particular dose of heparin you give to a patient, the response of anticoagulation is different because of this characteristic of the unfractionated heparin. It also initiates its own negative feedback loop by activating platelets. And by this activation, it causes the release of platelet factor 4 and von Willebrand factor. So it's kind of like it's working in our favor, causing anticoagulation in the patient. And on the other hand, it's also causing a negative feedback loop and mitigating its own response. As we discussed previously, it is unable to attenuate the clot-bound thrombin at lower concentrations, so you need a higher concentration to inhibit that thrombin which is already present in the clot. Thrombin which is already present in the clot, it will continue to form more clot. Another important limitation of heparin is it shows a non-linear half-life. And what do we mean by that is the response in the form of an ACT, which we use to measure the anticoagulation characteristic of heparin, is variable at variable level of dose. For example, if you're giving a patient, say for example, 10,000 units of heparin, the ACT is variable. It can be 100, 200. And the reason is one of the reasons is a bimodal clearance of the heparin. It is cleared by the endothelial cells and macrophages, and also by the kidneys. The other limitation, which is very important, is, as we discussed previously, it activates platelets and causes the release of platelet factor 4. And combined with platelet factor 4, the combination and the complex of platelet factor 4 and heparin, it can produce an immune response and antibodies against that complex, and can lead to a dreadful condition which is called heparin-induced thrombocytopenia, which we'll discuss in the coming slides. So this is a schematic presentation of heparin. If you notice, the last pentasaccharide is the most important in heparin molecule. This is the part where it combines with antithrombin 3 and activates antithrombin 3 to inhibit the activity of thrombin.